Focal impaired awareness seizures are focal onset seizures in which awareness becomes impaired during the event. The seizure begins in a localized region of one cerebral hemisphere and may remain confined to that network or spread to nearby regions. Although patients appear awake, they have reduced awareness of themselves and their surroundings. Simple activities such as visual tracking may be preserved, but higher cognitive functions including decision-making, comprehension, and purposeful interaction are impaired. Many patients experience an aura before awareness is lost. This aura represents the earliest subjective manifestation of the seizure and usually lasts from a few seconds to 1 or 2 minutes. Once impaired awareness develops, the seizure typically continues for more than 30 seconds, most commonly 1 to 2 minutes, although some episodes may persist for up to 10 minutes. Recovery is often gradual and depends on the site of seizure onset. The temporal lobe is the most common site of origin for focal impaired awareness seizures. Patients frequently experience characteristic auras such as a rising epigastric sensation, déjà vu, sudden fear, or unpleasant smells. During the seizure, oroelementary automatisms including lip smacking, chewing, and swallowing are common, along with manual automatisms such as fumbling or repetitive hand movements. Autonomic symptoms including tachycardia, flushing, and pallor may also occur. Following the seizure, patients typically have a pronounced postictal phase with confusion and gradual recovery over several minutes. The frontal lobe is the most common extratemporal site of origin. These seizures often occur during sleep, are usually brief at around 30 seconds, and may occur in multiple clusters throughout the day or night. Motor manifestations predominate and range from hypermotor behaviors such as pelvic thrusting and bicycling movements to asymmetric tonic posturing. Some patients exhibit bizarre behavior, sexual automatisms, or loud vocalizations. Unlike temporal lobe seizures, postictal confusion is generally minimal, allowing rapid recovery. Parietal lobe seizures primarily produce sensory symptoms. Patients may report positive sensory phenomena such as tingling and paresthesias or negative sensory symptoms involving loss of sensation. Sensorimotor disturbances are common. Vestibular hallucinations, visual or somatic illusions, and vertiginous sensations may also occur, reflecting the sensory integration functions of the parietal cortex. Occipital lobe seizures are characterized by prominent visual symptoms. Patients may experience elementary visual auras such as flashes of light or colored shapes, transient ictal blindness, rapid or forced blinking, and oculoclonic eye movements. As the seizure spreads, forced deviation of the head and eyes to the opposite side may develop. Insular lobe seizures, often present with viscerosensory symptoms that can mimic seizures arising from other cortical regions. Patients commonly report nausea, vomiting, excessive salivation, or other unpleasant visceral sensations. Because the insula has widespread cortical connections, these seizures may also produce mixed motor manifestations, making localization challenging without electroclinical correlation. Recognizing the characteristic clinical features associated with different lobes of seizure onset is essential for localizing the epileptogenic focus. Careful assessment of the aura, seizure semiology, duration, automatisms, motor and sensory manifestations, autonomic features, and postictal recovery provides valuable diagnostic information and guides further evaluation with electroencephalography, neuroimaging, and treatment planning.